Assalamu alaikum. Today we'll talk about uh, basics of the kidneys and chronic kidney disease. My name is Amjad Mir. I'm also a former graduate of Sindh Medical College, and you saw my credentials. Today, we'll briefly go over the basic anatomy of the kidneys, especially the functional units of the kidney, which is called nephron. We will discuss important kidney functions. We will also talk about some of the common drugs acting on nephron, which are clinically important, and signs and symptoms of kidney disease, and more focus on the chronic kidney disease. This is the front of the renal system. There are two kidneys in the back of the body and in the retroperitoneal area under the rib cage. The average size of the kidney is around 9 to 11 centimeter. Kidneys are filters, and the ultrafiltrate finally becomes urine and goes through the ureters and is stored in the bladder, and we void it when we have urge to void. And this is the cross section of the kidney. You see the renal artery and renal vein. Renal artery has multiple branches, and eventually it forms the afferent arteriole, which continues to the glomerular capillaries, which leads to efferent arteriole. And then efferent arteriole continues as peritubular capillaries and eventually drains into renal vein. The cortex, which is this part, is the a very important part because that's where most of the function of the kidney occurs. And then we have minor calyces and major calyces, pelvis of the kidney, and the ureter. Say, this is the functional unit of the kidney called nephron, and hence the specialty is also called nephrology. Glomerulus is a tuft of capillaries. Uh, Afferent arteriole brings the blood to the glomerulus, and efferent arteriole leaves the glomerulus. This is a unique situation because you see there is no venule here. Normally in the body, arteriole is followed by capillaries and then venules. Here, arteriole is followed by capillary and then arteriole again, and this efferent arteriole continues as a peritubular capillary, and then eventually becomes a venule and finally drains into the renal vein. And you see that this nephron has a glomerulus with the Bowman's capsule, proximal convoluted tubule, loop of Haley, distal convoluted tubule, and collecting ducts. So estimated glomerular filtration rate, which is usually calculated using MDRD formula. MDRD is modification of diet in renal disease. And it's a little different in African American and non-African American population, as there's a general consensus that African American population have more muscle mass, hence more creatinine, and their creatinine stays a little high. GFR is directly proportional to the net filtration pressure. And like any other capillaries in the body, the net filtration pressure is the hydrostatic pressure, in this case, hydrostatic pressure of the glomerulus minus the sum of the hydrostatic pressure of the Bowman's capsule and colloid-osmotic pressure of the glomerular capillaries. GFR is also dependent on permeability and surface area of the basement membrane. Then we have the proximal convoluted tubule, where about 65 to 70% of the sodium is reabsorbed. And the drugs that act on this area is osmotic diuretics like mannitol and urea. They work on proximal tubule and loop of Henle and increase the osmolality of the urine and hence the water loss. Acetazolamide also works on this area and inhibits the carbonic anhydrase and causes the loss of sodium and bicarbonate in the urine. Then we have loop of Henle, and here about 25% of sodium is reabsorbed. And the loop diuretics are called because they work on the loop ascending limb of the loop of Henle. They are the most potent diuretics, and they work on the thick ascending limb of the loop of Henle. They block the sodium, potassium, and 2-chloride channel. Loop diuretics work on the luminal side of the uh, nephron. And so they are protein bound, so the very little is filtered through the Bowman's capsule and glomerulus. So most of it has to be secreted across the proximal convoluted tubule by the organic anion transporter from basolateral, which is the interstitial side, to the luminal side and work on the ascending limb. Intravenous loop diuretics works much faster as compared to the oral ones. Then we have distal convoluted tubule, where about 5% of the sodium is reabsorbed, and thiazide diuretics work here. They block the sodium chloride transport channel in distal convoluted tubule. These thiazide diuretics can potentiate the effect of loop diuretics. To understand that concept, think about that. When loop diuretics block the sodium chloride and potassium channel, a lot of sodium is being in the lumen, and if there is no other channel to affect sodium reabsorption, or a lot of sodium will be excreted and the water will follow that. But we have here sodium chloride channel, which is usually opened, and when there's a lot of sodium comes from the ascending limb or loop of Henle, the sodium gets absorbed. Some of the sodium gets absorbed here in the distal convoluted tubule, and still more than usual sodium is excreted with some also the water loss. But think about it, if we can close this or block this channel ahead of sodium coming here with thiazide diuretics, and then give the loop diuretics, so a lot of sodium will be excreted in the lumen, and very few, if any, sodium will be reabsorbed here. So you'll have the potentiation of loop diuretics and loss of lot of sodium and water. Then we have distal convoluted tubule, which we talked about. And then in collecting ducts, less than 5% of the sodium is reabsorbed. Here we have potassium sparing diuretics, which work from the late distal convoluted tubule to the collecting duct. And they inhibit the epithelial channel, which is the epithelial sodium channel, and they cause loss of sodium and spare potassium. This is another busy slide, but very interesting. First let's go through the anatomy of it. This is renal corpuscle with juxtaglomerular apparatus. Afferent arteriole comes here, forms the glomerular capillary, and then efferent arteriole is right here, going out of the Bowman's capsule. You have epithelial cells, you have podocytes, you have foot processes, which are little spikes here, and then we have glomerular basement membrane. You have endothelial cells lining the inside of the capillaries, and we have mesenterium. So non-steroidal anti-inflammatory drugs, uh, they work on afferent arterial site. So the net effect on the afferent arteriole is the constriction by blocking the prostaglandin mediated vasodilatation. And then ACE inhibitor, which is the angiotensin converting enzyme inhibitors, they cause vasodilatation of the efferent arteriole by inhibiting the angiotensin converting enzyme, thus by decreasing the effect of the angiotensin 2. And by doing this, they decrease. So to understand this concept, because in board exam, the questions are a little bit uh, tricky, they will tell you that ACE inhibitor will decrease the vasoconstriction, which is same as causing vasodilatation. So when angiotensin is secreted, angiotensin is a potent vasoconstrictor. It causes vasoconstriction of this efferent arteriole. ACE inhibitor will block the production of angiotensin 2, and that thereby angiotensin will not be able to cause vasoconstriction. So in sense, it will cause dilatation of the efferent arteriole. When there is a dilatation of efferent arteriole, blood will pass much easily, and there will be a less intraglomerular pressure, which will definitely cause a slight decrease in glomerular filtration rate also. But these medications are very effective in conditions like diabetes and other conditions which cause proteinuria, because by decreasing the intraglomerular pressure, they also decrease the protein leakage in the urine, and which is very beneficial for the kidneys in the long run. Now, functions of the kidneys are removal of the waste products, removing extra water from the body, maintaining acid base and electrolyte balance, conversion of vitamin D into active form. So, from sunlight, we get ultraviolet lights, which convert the 7 dehydrocholesterol to cholecalciferol, which is vitamin D3, which is not active form. So vitamin D3, which is cholecalciferol, is converted into 25 hydroxy cholecalciferol in liver. And then kidneys convert it to 1-25 dihydroxycholecalciferol, which is the active form. And kidneys has the enzyme 1-alpha hydroxylase that can help that conversion. And these are all, again, the board type questions. Next is kidneys produce erythropoietin, which is normally produced by the interstitial fibroblast cells in the renal cortex, which is located in very close proximity to the tubular epithelial cells and peritubular capillaries. Then secretion of renin, and which is very important in blood pressure control. Renin is secreted by the juxtaglomerular granular cells. Its secretion depends upon the sodium chloride delivery to the and the reabsorption by the macula densa. And this is called tubuloglomerular feedback. So a little bit more about the renin-angiotensin system. That renin converts its substrate angiotensinogen to angiotensin 1. Then angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, mostly in the lungs, but it also occurs in the local tissues. Angiotensin 2 is a potent vasoconstrictor, and it also causes the aldosterone release. So both of them can cause blood pressure, high blood pressure. Aldosterone causes salt and water reabsorption and then hypertension. Now, a little bit about the chronic kidney disease. According to KDIGO, which is the Kidney Disease Improving Global Outcome, and they have defined the chronic kidney disease by the presence of kidney damage or decreased kidney function for 3 or more months, irrespective of the cause. Decreased kidney function refers to the decreased glomerular filtration rate, which is usually estimated using serum creatinine, and one of the several available equations like MDRD, modification of diet in renal disease, and also CKD-EPI, which is CKD epidemiology collaboration. So kidney damage is defined in most cases by the presence of albuminuria, urinary sediment abnormalities, anatomic abnormalities, which is discovered by the imaging studies, pathological abnormalities, which are discovered by kidney biopsy or a history of kidney transplantation. The overall prevalence of the chronic kidney disease increased significantly between 1999 to 2004, but then kind of stabilized in 2011, uh, including among the older individuals. And incidence of uh, end stage renal disease has stabilized, but the prevalence of ESRD is increased. And one of the reason could be that we are doing such a good job in keeping the dialysis patients alive with the new sophisticated dialysis machines. The stages of the kidney disease, there are five. Stage one has a normal estimated GFR with some evidence of kidney damage reflected by microalbuminuria, hematuria, or histological changes. Stage two is mild kidney disease with GFR between 60 to 89 ml per minute per 1.73 meters square. And stage three is moderate kidney disease with GFR between 30 to 59. Uh, and stage four is severe kidney disease with a GFR ranging between 15 to 29 ml per minute per 1.73 meters square. And stage five is estimated GFR less than 15. And at that point, the renal replacement therapy or transplant is considered to sustain life. So symptoms, kidney disease is often referred as silent disease, and patients can be asymptomatic, and kidney disease is often detected by blood test and evaluate elevated creatinine and abnormal urine test. Patients might have some weakness, easy fatigability. Uh, Very rarely we'll see decreased urine output with early kidney disease. Foamy urine can represent proteinuria. Then patient can also have microscopic hematuria. Some patients might complain of back pain. And when the kidney disease is worsening, then the symptoms might become more pronounced, like decreased appetite, nausea, vomiting, fatigue, increased sleepiness, itchiness, um, swellings, fluid overload, and then encephalopathies or even seizure. See. The diagnostic studies can start from the blood work, which can reveal renal functions, diabetes mellitus, anemia, and then you can uh, calculate the chronic kidney disease stages, autoimmune diseases like from antinuclear antibodies, excuse me, serum protein electrophoresis, uh, to rule out multiple myeloma, hepatitis panels, all can be done by the blood work. Urine studies can show some proteinuria, hematuria, sediments, crystals in the urine. Renal ultrasound can help with the diagnosis of chronic kidney disease by seeing some echogenic kidneys or obstructive uropathies like benign prostate hypertrophy, renal or bladder mass, polycystic kidney disease, renal arterial Doppler, especially in younger patients who have hypertension, can be done to rule out renal artery stenosis. CAT scan of kidneys can also be helpful in these diagnosis. including nephrolithiasis. This is the slide so to see the uh, kidney disease markers. Most commonly, we still use creatinine and urea, and cystatin C was also at one point mentioned. And in some places, they might do it, but not on the common regular basis. Common causes for the kidney disease is, diabetes is still one of the most common cause for the kidney disease, and it causes proteinuria. And it is a complex disease with overlapping etiological pathways, alteration in glomerular hemodynamics, inflammation, and fibrosis are the primary mediator of the kidney damage in diabetes. Hypertensive kidney disease, usually a patient has long-standing hypertension. It can cause ischemic nephrosclerosis. It causes slow worsening of the renal failure. And usually patients have non-nephrotic proteinuria and small kidneys on the renal ultrasound. Coronary artery disease and congestive heart failure are also very important cause, can cause cardiorenal syndrome in setting of low ejection fraction. Uh, in that case, we work with our cardiology colleagues to optimize the medications. Uh, Obesity can cause focal segmental glomerulosclerosis. Uh, Drugs will come, the drugs in a second. Polycystic kidney disease, it can present as a hypertension, hematuria, flank pain, obstructive calculi, and a family history of polycystic kidney disease. It usually manifests around age 50 and has worsening renal functions, possibly due to interstitial inflammation or apoptosis of the tubular epithelial cells, compression atrophy. uh, Treatment is nowadays the new medications, vasopressin V2 receptor antagonists have been involved, especially tolvaptan, with some success. There were some issues with the side effects. Uh, Glomerulonephritis from focal segmental glomerulosclerosis, membranous glomerulonephritis, membranoproliferative, lupus nephritis, hepatitis, chronic thrombotic microangiopathies, HIV nephropathy, IgA nephropathy, many more causes of glomerulonephritis. Contrast-induced nephropathy, in animal studies have shown that it can cause acute tubular necrosis due to direct cytotoxic effect of contrast on the tubular cells. Or it can also cause some renal vasoconstriction and medullary hypoxia, possibly because of the effect of the viscosity and alteration in nitrous oxide, endothelin, etc. Drugs, we know about the NSAIDs. Now we are also seeing interstitial nephritis with proton pump inhibitors. There are quite a few antibiotics which have adverse effect on kidneys, and herbal supplements, because they are not well regulated, uh, they can also have effect on the kidneys. Some of the drugs that we'll mention, starting from, again, this is the nephron, starting from glomerulus, proximal convoluted tubule, loop, and then distal convoluted tubule, and collecting ducts, like NSAIDs we already talked about, and gemcitabine. This is a pyrimidine antagonist, causes acute kidney injury and microangiopathic hemolytic anemias. Uh, NSAIDs not only cause acute kidney injury, they can also cause acute and chronic interstitial nephritis, nephrotic syndrome, membranous glomerulonephropathy, or papillary necrosis. Then we have lithium, which is cause impairment of the collecting duct concentrating ability, can cause diabetes insipidus or chronic tubulointerstitial nephritis. Interferon, is another common medication. That's prerenal acute kidney injury that we see, thrombotic microangiopathy, membranoproliferative glomerulonephritis, and tubular interstitial nephritis. Tenofovir, it's one of the HIV medications, can cause acute kidney injury with tubular cell degeneration, necrosis, interstitial nephritis, Fanconi syndrome. Uh, Commonly used antibiotic aminoglycosides can have direct proximal tubular cell toxicity and cause acute kidney injury. Vancomycin uh, can also cause acute kidney injury with variety of effects, and one of them is the apoptosis induced by accumulation of the drug in the proximal tubular epithelial cells. Cisplatinum uh, can cause DNA injury and tubular cell death, can cause low magnesium level, also diabetes insipidus in some cases. Acyclovir can cause deposition of crystals and acute kidney injury. So the main focus is this how we can slow the progression of kidney disease. Uh, and that can be achieved by doing quite a few things. Number one is controlling the underlying cause for the kidney disease. As we said, diabetes is the most common cause. uh, Having tight glycemic control, weight loss, uh, all these things, low carbohydrate diet, medication adjustment, can have effect on the uh, proteinuria and in progression of the kidney disease, treating hypertension with the guidelines, using ACE inhibitor, ARBs, and now new sodium glucose co-transporter 2 inhibitors, and optimizing the cardiac medications and functions, because as we know, there's some of the medications that have very beneficial effect on cardiac functions can have adverse effect on renal function, so working in collaboration with a cardiologist definitely helps the patient. Dietary restrictions, because the proteinuria usually is the most common important indicator of the kidney disease and GFR decline. So decrease protein intake and low phosphorus, low potassium diet, strict low sodium diet. When late CKD 4, we should start discussion with renal replacement therapy and options for renal replacement therapy, including hemodialysis or peritoneal dialysis. Besides these specific things, general uh, things that help the decrease the progression of the kidney disease is quit smoking, cutting down alcohol, losing weight, exercise, and staying well hydrated. Some of the medications that we can give during late stage of the chronic kidney disease based on what's going on with the patient, like if there is a persistent metabolic acidosis, considering sodium bicarbonate tablets. If patient has anemia, checking iron level and making sure we rule out other causes of anemia, and then starting patient on erythropoietin stimulating agents. Um, Bone mineral disease, checking parathyroid hormone levels, starting vitamin D if necessary, checking phosphorus level, considering phosphate binders, and of course, low salt and low protein diets with diuretics for edema. And these are some of the things that I just talked about, uh, asking the question, has kidney function declined? Kidney functions are decline at the predicted rate. If not, then what caused it? If there are any factors that can be modified, patient's lifestyle or diet, wise, and life-threatening conditions that will you have to make decision about initiation of dialysis is if patient has uremic pericarditis, refractory fluid overload, resistant hypertension, uh, refractory hyperkalemia, uncompensated metabolic acidosis. Uh, those are the things that you really worry about. And then once the GFR reaches less than 20 ml per minute per 1.73 meter square, you start discussion about renal replacement therapy with the different modalities, hemodialysis versus peritoneal dialysis, home dialysis versus in-center dialysis, and then we talk about the axis placement. So there are basically three major type of access for hemodialysis, which are if patients are on CKD4 or CKD5 and has not decided about the dialysis and something goes wrong and he gets sick and ended up in the hospital, then obviously if he requires urgent dialysis, then you place a central venous hemodialysis catheter, and the reasons would be, as I mentioned, patient is uremic sign and symptoms, hyperkalemia, severely acidotic, uremic pericarditis, encephalopathy, or fluid overload. As far as the access is concerned, there's AV fistula, arteriovenous fistula, and depending on the size of the vessel and based on the vein mapping, uh, evaluation of dialysis access is primarily directed towards the creation of AV fistula. But if patients has small veins, then other um, uh, type of access can also be done, like AV graft. Commonly used veins for the AV fistulas are radial artery and to cephalic vein, or brachial artery to cephalic vein. Usually it takes about 4 to 8 weeks for the fistula to vein to become mature and become functional artery and can be cannulated to start dialysis. AV fistulas are less likely to get infected, they last longer, and they have less chances of thrombosis. Uh, Once the fistula is ready, you place needle, one on the anastomosis side, close to anastomosis, which is the arterial side, and the blood goes towards the dialysis machine and goes through the filter and then comes back towards the venous mm, side to go back to the body. In dialysis, in the dialysis machine, there's a special filter dialyzer where metabolic waste and electrolytes go down the concentration gradient via diffusion and also via convective transport. Fluid is also removed via hydrostatic gradients. I'll talk a little bit more about it in a second. This is the other type of dialysis access, which is arteriovenous graft, which is a synthetic tube used to connect artery and vein. Uh, Prosthetic and biological graft materials are available for arteriovenous graft placement. A graft can be straight or loop, as you see in this situation. The graft is in a loop graft, and this is the arterial anastomosis, and the blood is flowing through the graft and going back through the venous anastomosis back to body. And this is the needles are placed in opposite directions, so the blood that's coming through the artery side goes to the dialyzer and comes back through the venous needle and goes back to the body. AV graft has higher chances of clotting, relative short life, and has higher risk of infection. As far as the cannulation is concerned, it's a very, very important thing to do a right cannulation, which is a rope ladder technique, and it has moderate but equal dilatation of the vein. But if you have area technique, which means that you continuously cannulate with the needles in the same areas, then you can develop these aneurysms and the stenosis in between the aneurysm, which can cause problem in the axis. In some places, buttonhole techniques has been used, and there are certain situations where the buttonhole uh, technique can cause infection in the tunnel. So this is the dialysis machine. You see that this line is the arterial line. It goes and across, goes through the tubings into the pump, which uh, pushes the blood towards the dialyzer. It's going up, and this is the red port. So that's where the blood is going. Blood is going from the top to bottom, and then you see these two connectors here. So this is the special dialysate fluid, which has bicarb and acetate mixed to have an optimum pH. And dialysate fluid goes from bottom to top in a countercurrent mechanism, just like we have countercurrent mechanism in kidneys, loop of Henle between medulla and cortex. And then uh, exchanges occur here, diffusion and convective forces and hydrostatic forces remove the fluid and toxic waste products. And then relatively cleaner blood goes back through this tubing. There's some air bubble filled chamber, and here's it goes back to the patient's body. The other modality is peritoneal dialysis, which is one of the home dialysis modalities and can work well as long as the therapy for the most of the patient. The ideal candidate will be somebody who's willing to perform their own dialysis at home and are very compliant, and they have minimum or no abdominal surgery, because once you have the abdominal surgery, you can develop some adhesions, and that can cause problem with drainage of the fluid during peritoneal dialysis. And also, patients will usually need to have a suitable storage space at home for putting the supplies. It's good to have patient some residual renal functions, and because that residual renal function can stay with patient for long period of time in peritoneal dialysis. There are two types of peritoneal dialysis procedures that's done. One is called manual dialysis, that patient, every cycle that patient does, they do it manually by attaching the uh, bags. Like this is one of the pictures of peritoneal dialysis. This is the peritoneal catheter that goes into the peritoneal cavity, and the catheter tip is outside in the body abdominal wall. When it's time to do the dialysis, these are the special dialysate fluid, which is either dextrose base or non-sugar base, and the tubings are connected to the dialysis catheter. This fluid goes into the abdominal space, in the peritoneal space, and as the fluid touches the peritoneum, there are three barriers, that's the capillary wall, interstitium, and mesothelial cell layer. Uh, and so, among these three, the capillary wall is the most important barrier, because it has pores, ultra small pores, and large pores. Ultra small pores are a good transporter for the water, and the small pores are the most abundant, and uh, they transport low molecular weight solutes. So by diffusion and convection, the toxins and water comes into the uh, sorry toxin and water comes is into the cavity, and after keeping the fluid for about an hour or two, which is called the dwell time, uh, we remove the fluid. When the fluid is drained out, some of the toxins and extra water also comes out, and then you repeat the cycle. You can do these cycles manually 3 to 4 times a day, or you can use an automated machine which is called cycler, which can be placed right next to your bed, and the machine is programmed by the dialysis nurses, and all the patient will have to do is that at the time when they're ready to go to bed, they put some special fluid solutions on top of the machine, and connect the tubing to the catheter and turn the machine on. The machine does all the work, bringing the fluid in, keeping it for 1 to 2 hours based on the prescription, and then draining it afterwards. So throughout the night for 8 to 10 hours, this cycle continue, and while patient is sleeping or resting, and in the morning when patient wakes up, peritoneal dialysis is done, and patient has all day during daytime to do other stuff. One of the studies that came out in 2006 in American Journal of Nephrology shows, which was a prospective randomized study, which shows that this automated peritoneal dialysis that is done at nighttime provides significantly more time for work, family, and social activities than the continuous ambulatory peritoneal dialysis. So the patients do much better. Uh, and overall, those patients who do the dialysis at home, they do much better because they are at home, and they don't have to travel to in center to get dialysis 3 times a week. This is data showing that ESRD population in 2003 from the countries that were available. You can see uh, Taiwan versus Bangladesh. Some of the contraindication for dialysis modalities is especially in peritoneal dialysis, it's like I mentioned, loss of peritoneal functions or membrane, or patient has adhesions blocking the dialysate flow, uh, uncorrectable abdominal hernias, diaphragmatic leak can happen. In hemodialysis, issues of no vascular access. This is very important because in hemodialysis, the patients, their veins are the most important things for as far as the access is concerned. And when the patients have chronic kidney disease, stage 3 and in stage 4, we try to save their veins uh, even when they are hospitalized, and trying to use the veins below elbow so we can save the upper arm, cephalic, and basilic veins. So down the road, when patient will need fistula or graft, they have decent veins, and that helps the patient a lot. And beside after dialysis, the other option is the kidney transplant, which can be done by preemptive transplant, like patient is uh, very close to end stage renal disease and they have any living donors, they can get blood typings, and if there's a match, they can do a kidney transplant. Or there is a cadaveric kidney transplant system that you can enroll every dialysis patient can enroll there and wait for their turn for kidney transplant. Uh, and this is something new that's still in progress and research. Wearable artificial kidneys. Uh, Hopefully, that will be sometime in future that we can come up with something much better that patients can wear and clean their blood without going through the dialysis centers or doing all the major access. Okay. I hope you have paid attention and some of the concepts that I talked about, you understood that, these are bulk of the slides that I presented are based on the board questions and USMLE questions and some of them if you want to go into nephrology, definitely it's going to be a big thing to understand and have a concept. If you didn't understand something that I mentioned, please go and uh, find some online resources to understand better. Thank you very much.